you. So yes, I got interested in lifestyle modifications. I would say probably during medical school, and didn't realize that there was something out there called lifestyle medicine. So when I found that out, I just kind of dived deeper into what that is, what that entails, but then found out that a lot of people get discouraged. Providers get discouraged, patients get discouraged, and that's because there are barriers to implementing these lifestyle modifications. So that's what I'm going to be talking about today. Also, it's going to be through the lens of rural health and rural medicine, because that's where I'm working at currently. So, what is lifestyle medicine? So, specifically, it is a medical specialty that focuses on lifestyle changes. It can be on changing how you eat, changing your physical activity, but it also includes sleeping. It also includes stress management, avoidance of risky substances, and positive social connections. And they look at this as it connects to treatment of chronic diseases. For me personally, I tend to use it more for type 2 diabetes, cardiovascular diseases, and obesity. However, it can be applied to many other diseases, more than just those. So the reason why I tend to focus more on these is because of these reasons. So these are all coming from the CDC, looking at prevalence of different chronic diseases. So as you can see, prevalence of diabetes, and this is for people 20 years and older as of 2019. So as of 2019, 34.2 million people have diabetes. That's about 1 in every 10. And of those people who have diabetes, 1 in every 5 don't know they have diabetes. These numbers almost triple when you add in pre-diabetes. So it's about like 88 million when you add in pre-diabetes. And unfortunately, about 9 out of 10 of those don't know that they are pre-diabetic. Hypertension. So basically, 1,000 deaths a day can be contributed to hypertension. This snapshot says 1 in 3 American adults have high blood pressure. I've also seen where it says 1 in 4, so we're kind of in the middle of that. And of course, high blood pressure, people are at higher risk of stroke, people are at higher risk of heart disease, and about 1 in 5 could have chronic kidney disease, which leads to a whole host of other things. Again, the CDC, you look at the prevalence of hypertension, prevalence of stroke, prevalence of heart disease, and you see that where there's more hypertension, there's more stroke, there's more heart disease. So, chronic diseases in America, about 6 out of 10 people have a chronic disease in the United States. 4 out of 10 have 2 or more, and chronic disease is the leading cause of death and disability in the United States, and is the leading driver of the $4 trillion cost of annual healthcare. So just to kind of break that down a little bit, if you spend $4 in healthcare, about 3 of those $4 is based off of chronic disease. Healthcare costs for people with chronic disease is 5 times higher than those who don't have a chronic disease. And then you look at prevalence now. Basically, 1 out of 3 children born today will develop a chronic disease. If you're looking specifically at Latino children, we're now at 1 in 2. And then those with chronic diseases, about 25% of them are going to develop some type of activity restriction, restriction to mobility, or some type of decrease in quality of life. So here's the thing. Out of the 10 leading causes of death, 7 of them can be directly improved with lifestyle modification. And when you look at the different modifications, whether it is smoking, alcohol use, eating, physical activity, they account for 90% of the $4 trillion in annual healthcare spending. So then today, I talked a little bit about it. We're going to focus on mainly healthy eating habits, physical activity, and behavior modification. I'm going to leave off like the stress management and the social connections because it's a little bit out of my scope as of today. We'll also look at the barriers to patients making these changes and how we as primary care can help our patients overcome these barriers. So first thing, let's talk about healthy eating. Diet, most significant risk factor when it comes to disability and premature death. So when you look at lifestyle behaviors, they are responsible for 40% of all premature deaths. And then according to the Academy of, I think it's called the Academy of Lifestyle Medicine, 80% of chronic diseases are preventable. So when you look at the Western diet, or the diet that most adults are eating, again, my research is more in adults, not so much in children. US adults constantly are over-consuming processed foods, fats, salts, sugars, and refined grains. But then when you look at the diets that are out there, especially more of the fad ones, they focus mainly on weight loss, not really focused on better nutrition and overall health. So that has become the new focus, according to the USDA, that we're trying to push more toward good nutrition and health benefits, not so much focusing on what you need to eat to lose weight. Physical activity. So we all know that with physical activity, it helps decrease risk factors for cardiovascular disease, improves outcomes for things like diabetes, hypertension, osteoporosis, and it also decreases risk of certain cancers. But the thing is, you don't want to ignore that it's also good for mental health. You can't exercise and be stressed and anxious at the same time. It's physiologically impossible. So exercise is helpful for stress, anxiety, treatment of depression, and also improves sleep. And of course, if you're working out more, you're going to burn more. So it's very helpful with the treatment of obesity. And obesity is a linked risk factor to over 25 chronic diseases. So it was 25, but then when COVID came along, it made it 26. I haven't researched if there's any more than that at this time. So when you're looking at physical activity, different disease states require different amounts of physical activity to see a change. But universally, you usually start off a patient on 3 days a week, 20 minutes of aerobic activity. You want to emphasize aerobic there. And a good goal for most patients is 30 to 60 minutes, 5 times a week. That's like what they're trying to get to. So they start at 3 times a week and they get to 5 times. Lifestyle modifications, so behavior modifications. Basically here we're talking about, I'm talking about smoking and alcohol use. We know that these tend to exacerbate all kinds of diseases. Smoking more focused on cardiovascular and pulmonary conditions, whereas alcohol use can affect almost anything. So we know, just as providers in the healthcare system, we know modifying lifestyle helps with chronic diseases. So much so that in 2010, the American Medical Association said that physicians should implement evidence-based lifestyle interventions as first and primary mode of disease prevention. The US Task Force said that they recommend counseling for healthy diet and physical activity for adults without cardiovascular risk factors. That's a grade C. And then routinely for those with cardiovascular risk factors, and that's grade B. So if we all know that this works, why isn't it happening? What is keeping patients from implementing these lifestyle modifications that we know will help them down the road? So one main barrier is health literacy. A lot of times if patients don't understand what's wrong with them, they're not going to make any changes. Especially if whatever condition they have is not causing them any type of pain. I would use my mother as an example. She was diagnosed with diabetes about 30 years ago and didn't do anything about it until it was almost too late. And when I asked her, what do you wish the doctor had told you? She said to me, I wish I had known how serious this was, because I would have taken care of it before if I had known how serious it was. Again, going through the lens of rural health, many rural residents experience challenges obtaining health information. This is due to a multitude of things. Decreased access to healthcare, a healthcare provider. A lot of the written information that's out there is written at a language that exceeds their reading level. So even though they have this paper or have the website, they still don't understand what's going on. And then some of the concerns brought up is that when they're having conversations with their healthcare provider, the conversations are short. It involves a lot of larger words or medical jargon that they don't understand. And from the patient perspective, it feels largely one-sided. So it feels like the provider is doing all the talking and they don't get to say anything and ask any questions or anything like that. The next one is, so what's going on when it comes to healthy eating? So a lot of the way that people eat is very much put together by a lot of different reasons. One is culture. You tend to eat like the people around you. You tend to eat like your family. You tend to eat like your friends. You tend to eat like your coworkers. So, and again, I'll use my family. I am from the South. I'm from Virginia. In the South, if you don't know, our cuisine of choice is fried. We fry everything. So if grandma fried it in lard, mom fried it in lard, you fried it in lard too, you don't know any different. We tend to cook our vegetables to death in salt water with some piece of pork. So if you don't know how to make vegetables lower calorie, then again, that's a barrier for you. Emotion. So what I mean by that is when people are tired, when people are stressed, when people are overworked, they tend to have less willpower to make healthy choices. They tend to fall back into old habits. Also, when they're hungry. This is why we tell people don't go grocery shopping when you're hungry, because then you will be more prone to making bad decisions. Finances. Finances are huge, especially in rural areas where social economic status tends to be lower. Patients, for some reason, assume that eating healthy equates to being expensive. And that's usually due to the fact that if you look at how much apples cost and you look at how much ramen noodles cost, there is a huge discrepancy. And so they're like, I can't eat healthy because I can't afford it. Knowledge. A lot of times patients just don't know. What does healthy eating mean? What does it mean? I had a patient who said that I'm eating more vegetables, doc. I don't know why I'm not seeing the results. And I was like, okay, well, what kind of vegetables are you eating? And as we kind of dig into what's going on, oh yeah, I'm eating all the vegetables at the all-you-can-eat Chinese food buffet. And I'm like, okay, so we're headed in the right direction, but let's talk about, how that is not the healthiest of healthy vegetables, okay? Lack of satiety cues. There are some people who they've eaten this way for so long that they don't feel full. Usually these are people who have been told when they were young, you got to clean your plate. So even doesn't matter the size of the plate, even if you felt full, they still feel the need to finish everything in front of them. And you have to tell them that that's really not needed, or have maybe smaller plate, something like that, right? Mindless eating. These tend to be people who they're eating when they're doing some type of activity, watching TV or something like that. So they are not paying attention to the cue that, hey, I'm full. And then there's emotional eating. The patient does not feel hungry at all. Instead, what's happening is they're feeling some type of emotion. I'm happy, I eat. I'm sad, I eat. I'm bored, I eat. So therefore, there's no saying that I am full or I'm hungry there. Cooking skills. I run into this more than what I thought I would. You tell people, hey, don't eat out. You need to cook at home. It's healthier to cook at home. And then you find out that they don't know how to prepare food. They can go out and they can buy it, they can afford it, but when it comes to actually making something that they want to eat, they don't have the skills to do it. And then time, because preparing food for yourself takes time. All right, physical activity. Some people just don't know what to do and where to start. They don't know what exercises are good for them. They don't know how often they should be working out. They just don't know, and this lack of knowing leads them to not try. They don't have an area to work out. Again, this is more of a rural focus. Here we have a singular gym, and it's not, we have a singular gym. And then there's limited places where you can do like outdoor activities. There's not like a great big park or anything like that. We don't have access to like many exercise classes or anything like that here. A lot of people who do have access to exercise classes, it is very creative. Like my best friend was a personal trainer 5 years ago, and so I just go over to his house and we work out in his garage. That's the kind of stories that I hear here. So therefore, limited access. Um, and then physical limitations. Some people, their bodies just will not cooperate with certain exercises. Their back hurts, their knees hurt, their hips hurt, their shoulders hurt. And so we tell them, hey, work out 5 times a week. It's not going to happen. And then counseling. So here especially, we don't have access to specialists who are used to doing this type of lifestyle modification, counseling, and education. So health educators, nutritionists, dietitians, personal trainers, things like that, we just don't have access to out here. And another thing is that providers themselves may not feel confident or just may not have enough knowledge to incorporate this counseling. Again, I'll always use myself as an example. When I was a resident, I remember turning to a fellow resident and saying, I tell my patient that they have hypertension and they should do the DASH diet. And I looked this guy right in the eye and said, what is the DASH diet? And he looked at me and he said, I don't know. So we tell people things that this is what you're supposed to do, but we as providers, we don't know it ourselves. We just know that this is what you should be doing. And we hand them a piece of paper, but we don't know what it is ourselves. And so then I asked another question. I was like, so when somebody asks you, what should I eat in order to control my blood sugar? What do you say? He's like, oh, I send them to a diabetes educator. And for me, that's probably why I like lifestyle medicine. That wasn't enough for me. I felt that, I'm a doctor. I should be able to understand what the Mediterranean diet is. I can read, but there's a lot of providers out there who are not comfortable because they don't know. They know that it's important, but they don't have that information kind of at their fingertips. So how do we overcome these barriers? This is a phrase that I use with all my patients who are trying to change their lifestyle, because changing lifestyle is hard. Change what you can change. We always go like low and slow. I don't try to change everybody's life in one 30-minute visit. That's not going to happen. So how do we make sure the patient understands what's wrong with them and why it's important to make these changes? The first thing that we should do with patients is ask them, what do they understand and what do they not understand? Some people, you're going to start at zero. They understand nothing. Some people understand some. Well, my aunt had this, so this is what I know. Some people understand, but they don't understand everything correctly. So you're just kind of untangling knots here. For me, I tend to personally ask them, what questions do they have before I start explaining anything? That way we don't have that whole, it's a one-sided conversation. The conversation starts off with, what do you want to know and what do you understand? Let me ask you questions and then we go from there. And then there's also the teach back method called the show me method. Once you have finished, giving this information, have the patient explain back to you what they understand. This lets you know that they understood you, or let you know that they didn't quite understand you, and you have to kind of go back and like smooth out the rough spots. Having handouts that are easier to understand. We have a lot of handouts that use a lot of medical terms, a lot of words, and they're in black and white. I will tell you exactly what happens to those handouts. The moment that they're out the door, they're all going in the trash. Or they're going to go on a table somewhere, get covered by mail, and they're never going to see it again. So I tend to use handouts that have more pictures and diagrams versus words. I also try to do things that are in color. People tend to remember color more than they remember black and white. My go-to resource is familydoctor.org. They have basically patient-centered explanations for almost every chronic disease that you could think of. They have resources that talk about exercises for seniors, healthy eating for teenagers. I mean, you name it, they have it. So I like that a lot. And then giving bite-sized amounts of information. I'll talk about myself. I have a tendency to give a whole bunch of information at one time, and then they remember about 50% of what I said and then forget the other 50%, which is probably the 50% I wanted them to remember. So I try to give it small, bite-sized, digestible information, and then the handouts will go into more detail about what I spoke about in the clinic. So my next few slides are just kind of examples of handouts that I have used previously. This one is the DASH diet. I have a couple more about DASH diet if they want more specifics. But basically, it focuses on whole fruits, limiting red meats and sweets, limiting salt, using spices, herbs, and lemon juice. So again, bright picture, something easy and digestible. And then I put the medical jargon in parentheses, but basically what this means. So the Mediterranean diet pyramid, so basically, again, it's pictures. It tells them how many servings a week or a day, and something. And if they have questions about it, then I can talk about what this means and all of that. So eating habits. How do we address these barriers? Well, one of them is like, we have to understand where the patient is coming from right then. What is your eating right now? I do this one of two ways. If I know that they're coming in to talk about this is usually my weight management patients, I have them keep a food log. Write down for me everything that went in your mouth, a week before you get here. If I don't know, and this happens to be a topic of conversation that comes up during a visit, I have them do a 24-hour eating recall. What did your breakfast look like yesterday? What did your lunch look like yesterday? What did dinner look like? What snacks? How much water? That type of thing. And then kind of understanding which diet and or healthy eating plan works best for your patients. I tend to focus on the main ones that have shown change via research. So that basically is the Mediterranean diet, the DASH diet, and plant-based or vegetarian. So I know those pretty well. Now, when patients start coming to me with other diets, like what about South Beach and what about keto and what about, I think I know more about keto just because, keto is used a lot with diabetes, but with other diets, I tend to have to either do the research myself or have the patient kind of bring in what they know and like, well, let's go over it together because I think on the next slide we talk about just understanding the basics of healthy eating. So the USDA put out Choose My Plate. That's this picture over here in the corner. So for people we're starting out at 0, I usually just start with this. I don't change anything about their calorie intake, their carb intake. I change nothing. I'm just like, make your plate look like this. Come back to me in a month and let's see what happens, right? Also portion sizes. I think a lot of people don't know anything about portion sizes. And so I have a handout. It's going to be my next slide where basically you just use your hand for measuring out your food. Because a lot of people are like, oh, I don't have a scale. That's fine. Let's just use your hand. Extra credit. You don't have to do this, just extra credit. If you just happen to have a few quick, easy recipes just off the cuff in your pocket, ready to go. I tend to use this with patients who they're trying to put foods that they normally don't eat into their diet, and this is usually vegetables. So I'm like, well, try this, we'll try that. And also they tend to be easier to cook. So I also use it for people who don't have higher cooking skills. If they're like, oh, no, like I just want my food to be more exciting. I can only eat so much grilled chicken. I'm like, okay. And so I usually send them to a resource where they can go look up recipes for themselves. You want to make goals, and then you want to make SMART goals: specific, measurable, achievable, relevant, and time sensitive. Again, this is why the whole just eat better does not work, because what does that mean, right? So I tend to give them something that they can hit. Like, let's increase the amount of vegetables in your diet. I want you to go from 0 servings a day to 3 servings a day. I want you to increase the amount of water you drink. I want you to go from 3 water bottles, and I show them, like, I bring them in the room. This. I want you to go from 3 to 4. That's the first thing, right? I want you to decrease the amount of soda you're drinking. I found that telling people don't do this, don't do that, that's the first thing that they're going to run to. So if I tell them don't drink soda, they're going to like instinctively want to drink more soda. So I say, let's decrease the amount. You're doing 5 cans, let's do 4 cans. If you go to 3 cans, bonus, great. This is the one that I was talking about, the portion sizes. So basically just using your hand when it comes to carbs, when it comes to vegetables, when it comes to protein, dairy, that type of thing. So I always have this on hand just to kind of hand out. All right, increasing their physical activity. So basically with this, and I got this from when I did an obesity medicine rotation. It's called the FIT model. Frequency, intensity, time, type, and enjoyment. So I tend to ask people, well, what have you tried before? What worked for you? What do you like? What do you not like? What are you interested in trying out? Because if I tell them, oh, go ride a stationary bike, it's good on the knees, and they hate riding bikes, then they're not going to do it. They're going to say, okay, doc, and then they're going to leave and they're not going to do it. But if they're like, oh, I would love walking, but it hurts my knees, I'm like, well, what do you think about swimming? Because there is access to a pool here. So it's like, what about, water aerobics or something like that? Exercise prescriptions. I find that when you give a prescription for medication, the same way you give a prescription for, hold on, I think I'm about to say it backwards. When you give a prescription for exercise, the same way that you give a prescription for medication, patients tend to take it more seriously. Also, you're setting up SMART goals on that prescription. You're going to do this exercise this many times a week for this many minutes. And so the goal is to get here, right? And then, of course, when it comes to physical activity, if your patient can have an accountability partner, it works so much better. Whether it is a family member, whether it is a friend, whether it is a coworker, having someone else there to go and work out with, or to call you and be like, hey, where are you at? You said that you were going to come walking with me, tends to increase them actually doing it and sticking to it. So this is the exercise prescription I tend to use. I can't remember what the acronym stands for. It's from the ACSM, and it's on their website, and you can download it. So basically here, aerobic training, strength training, again, being very specific, days per week, minutes per day, how many total minutes per week. Now, if we had PT or a personal trainer, I would definitely kind of put this here as of, hey, you're going to go see Mike and all that kind of stuff. But we don't have that here as of yet. So, and then when it comes to goals, so for high blood pressure, you're talking about 120 to 160 minutes a week. For diabetes, it's 150 minutes a week. And for weight loss, it's 300 minutes a week. Now, and I tell my patients all the time, I don't expect you to start here, but this is the end goal. This is where we're headed. This is where we're going. And this physical activity has to be aerobic activity. People ask, well, how, doc, how hard should I be going? I was like, I want your heart to beat a little fast. I want you to get a little glisten on the forehead. And if you're able to hold a conversation, you're not working hard enough. So behavior modification is probably one of the more difficult ones, because you have to assess where your patient is. Are they, and what is their goal compared to your goal? Because I would love for some of my people who smoke to just quit 100%, just like put it down. I would love that. But instead, they're like, I just want to cut back. I want to go from 3 packs a day to 2 cigarettes a day. Okay, okay. I want to go from 3 packs a day to vaping. It's like, okay. So again, a conversation that needs to be had, but you are figuring out where your patient is. And then sometimes your patients are just not there. They're not ready for it. They're like, you know, doc, you got me out here changing my diet. Don't take away my beers. I was like, okay. So we do one change at a time. But I usually warn them. I was like, okay, I won't take them away yet, but I'm heading in that direction. That kind of gets them contemplating that, oh, well, maybe I should cut down a little bit, that type of thing. And then, of course, giving them resources like the Quit Now cards, which is basically help with smoking cessation. Here at TRC, we do have behavioral health counseling that kind of helps with the reasons behind why they have certain behaviors. And then how do we help providers increasing their confidence? I usually find that confidence is low when the knowledge base is low or not there. So increasing your knowledge tends to help out a lot. I usually start with like the basics, just what are the basics of healthy eating? So Choose My Plate by the USDA, very simple and easy to go through. If you want things that are a bit more giving you numbers and evidence-based, the elements of healthy eating that was also put out by the USDA, that's the healthy guidelines of 2020 to 2024, talks about all of the food groups, oils, fats, salts, beverages, everything is in there. The AAFP has CMEs for lifestyle medicine. I think majority of them are online, but I do know that there was a conference that they did, I would say last October. The American College of Lifestyle Medicine, of course, also has online CMEs and conferences. The Obesity Medicine Association, that's where I learned a lot about the different diets and what they're for and who they help out. So they have a book that they've put out that, again, very, very helpful. I found the rotation, it was a 4-week rotation, to be very, very helpful. Again, diets that have been proven to support change. Mediterranean, DASH diet, Choose My Plate, and the Healthy Eating Plate by Harvard University. So the Healthy Eating Plate basically is Harvard, very, very smart, took the Mediterranean diet and then put it in a Choose My Plate format and said Healthy Eating Plate. Have your elevator speech ready. So we don't get a lot of time with patients. Very rarely do we get like a whole hour to sit and just talk about lifestyle modifications. So I find that if you have a little 2 to 3 minute kind of elevator speech that you toss out to say, just to start the conversation. The one I like to use a lot with my diabetic patients is comparing water and syrup. Because they understand flow of water and they understand flow of syrup. And so when I say that you have decreased blood flow, and that's why this happens, that's why this happens, that's why this happens, they innately kind of understand. And then I was like, well, how do I turn the syrup back into water? I have to get the sugar out. Well, how do I do that? Well, you have to eat less sugar. So I've already talked about the healthy eating that dives right into that. Or I got to find some way to get you to burn that sugar off. And so now we talk about physical activity. And then I think the more you do it, the more you become used to this becoming part of the management plan. I think right now, a lot of providers see that it's extra that's tacked on. It's not part of the actual management plan. But the more you do it, the more it becomes integrated in how you treat your patients. So resources being limited. A lot of times you just kind of have to hunt down what's available to you. So I got here and the first thing that I ran into was like, we don't have a diabetes educator. We don't have a nutritionist. We don't have a healthy eating educator. We don't have any of that. I found that there's actually a resource called Ideas for Cooking and Nutrition by New Mexico State University. And they actually have a satellite building here in Truth or Consequences. And so I just kind of got, in contact with her and be like, hey, what can we do to kind of connect you with the patients that we have here at the clinic? Another thing is like, not having access to like healthy foods due to finances. Well, Roadrunner Food Bank contacted us and started the Mobile Express Food Bank here. And so basically that food bank just focuses on fresh produce. So once a month, people can come here and get fresh produce until all the food runs out. And then farmers market. So we have a farmers market here that accepts EBT. So at least I know that during the spring and summer months, they can get fresh fruits and vegetables via EBT. I try my best to use as many online resources as possible. So my recipe websites, my favorite one is Food 52. Again, you have to be careful though, because cooking skill. The reason why I like Food 52 so much is because you can put in certain parameters, vegetarian, vegan, diabetic, breakfast, lunch, dinner. Is it an entree? Is it a snack? And you can click all these things and then they will give you all of these recipes. So that's my favorite so far. Online food journals, fitness trackers, and then having information resources. How do I teach myself, or how do I get handouts that are easy to digest that I give out to my patients? So again, the CDC, the NIH, the USDA, also resources that I could hand out to my patients. Like if you have further questions, this is where you can go to look it up and read. And then online workout resources. So a lot of people, I ask, well, can you work out at home? Is that a thing that you can do? And they're like, yes. So using YouTube, using Fitness Blender. I'm going to plug Blogilates here because it's my favorite due to the fact that a lot of the cardio videos on Blogilates doesn't have jumping or like strenuous activity. So it's helpful for people who have, bad joints. So yeah, in conclusion, about 6 out of 10 adults in the United States have chronic diseases. 4 out of 10 have 2 or more. But 80% of those chronic diseases are preventable. And 7 out of 10 leading causes of death can be improved with lifestyle modifications. And of course, the AMA says that physicians should be implementing evidence-based lifestyle intervention as first and primary mode of disease prevention. So it can be a little bit daunting. It can get a little frustrating. Making changes to a lifestyle is not easy. So we want to do as much as we can for our patients so they can, to help them make as many changes as they can. So thank you guys so much.
All right, so now we want to go ahead and open it up to questions from the audience.
Dr. Palin, hey, it's Dr. Endazola. How are you?
Good. How are you?
Good. You look awesome, by the way.
Thank you.
This is an incredible talk. I think you did a really, really good job, and the importance of this talk was well stated. I think we need to make changes, and these changes need to occur on a bigger level. I was having a lot of thoughts when you were talking about a lot of these things that are happening. The Institute of Medicine a few years ago published something on something, and I can't remember the exact article or the author or any of that, but there was a quote, and the quote said, "It's unreasonable to expect lifestyle changes when everything in a person's social and cultural environment conspires against that change," right? And I think about this guy, Sir Michael Marmon, several years ago, did this famous study in England where he found the further you live away from a green space, the higher your risk of cardiovascular disease is, right? And that's kind of like built environment. And, because it would be really cool if when they were at school, they got tons of education on healthy diet. And they got it in elementary school, and they actually got healthy foods. And then they got it in high school, more education in high school, and they got healthy foods, and they got more education in college, and they got healthy foods. So it's just part of what we do. So they know what's good for them, and the food is actually provided to them. I don't know about high schools right now or the rules, but I do know there's been a lot of high schools that have sodas and soda machines and hot Cheetos, and and certain districts have made movements to remove those from schools. Um, so I think that's one thing. I think the other thing is building an environment where you are always moving and always active. So one is changing the social structures so you can eat well, and then changing the social structures so you can exercise and have a walkable community or a rideable community and bike lanes, or I don't know, a free bike to everybody who graduates high school or something. I don't know. Those are more structural changes at a community level instead of single individual interactions. What do you think about that? Have you heard about that? Any strategies around that? What do you think?
So yeah, I absolutely agree that, if healthy eating, all that kind of stuff was implemented at a younger age, you just become healthier adults and you have those habits already. So what I know that is being done here, so the Behavioral Health and Wellness Council here at Sierra County, are working together with the public high schools, and they have a wellness week. More specifically, it's more about mental wellness, but they're trying to implement that, hey, eating healthy also affects your mental well-being. So it was the first year they've done it this year. It went over pretty well. And they're going to be doing it again next year. And I don't know if it's going to expand outside of the high school, but they invited over the lady from ICANN from NMSU to just talk about healthy eating, cooking, nutrition, and that type of thing. So we understand that it needs to be implemented. Going about implementing it in creative ways is kind of where the planning kind of needs to happen. I don't know what we're doing right now about exercise. I do know that the CEO of this hospital, what he wants to do is to create a space where people can not only come and get their physical therapy, but also can use it as a community gym, getting more access to places where they can work out. But again, that's more like several years down the road, but there are thoughts about just adding more things that community can have access to.
Oh, that's awesome. It sounds like you guys are already several steps down the road into making that. When you mentioned about your CEO, there's a critical access hospital in Lovington, New Mexico, and I just went to go see it. They built this massive gymnasium, natatorium thing. And they're a 20-bed hospital, right? But they have this massive exercise center that they built and provide classes and foods and just availability of equipment and opportunity to walk around a track that's air conditioned and stuff. So yeah, communities can do that. So that's really exciting. It really is.
I think there is a question in the chat, so I will read this. Thank you for your talk. You might have mentioned this, but have you created material yourself that has been written in plain language for your patients? And what do you recommend that other providers and residents do learn more about the importance of advocating health literacy in your practice? It also seems like health literacy is not quite catching on, and some have said that this needs to come from the providers themselves. Okay, so first question, have I created material myself that has been written in plain language? The answer is yes. So I cheated a little bit. It was part of my residency project. So it wasn't so much about lifestyle modifications. It was more geared toward preventive medicine. But it was basically a handout about, why do we do pap smears? And so again, plain language. And the way that I did it is I handed it to my younger sister and said, do you understand this? My younger sister is a fashion designer, you know, way far away from medicine. So if she understands what the highlights are, then I did a good job. If she has questions, that means I need to go back to the drawing board. Now, written material for lifestyle modifications, no. But I have done a couple talks for the community on diabetes and hypertension and healthy eating. And so I tend to use very plain language in those talks. And each person who attends gets to go home with the PowerPoint presentation. And I tend to use a lot of pictures. Like when I explain diabetes, there's a small diagram and there's an X here that this is what's going wrong and that type of thing. Let's see. What do you recommend that other providers and residents do to learn more about the importance of advocating for health literacy? That's a very good question. The answer is I am not entirely sure, because when it came to, because for me, when I was a resident, it didn't hit me hard. Well, it didn't hit me real hard about how important health literacy was until I started asking patients, well, why? You know, well, like, oh, well, I don't take my medication anymore. Well, why? And opening up that dialogue. I think a lot of times what happens is we are trying to get all the answers right, and we're trying to get everything right, and we're trying to get the management right, that we skip over the part of, does the patient understand what I'm telling them? Something that we do at the clinic here is, like, when a new patient comes in, we ask them, well, how far did you go in school? So if I already have that set up, like, oh, you didn't get past the 10th grade, then I might have to change the way that I explain something. Versus someone says, oh, I got my master's degree in health science. I'm like, oh, okay, you understand what I'm saying. Health literacy not quite catching on. I don't really have the answer on how do I push that to make it more important, aside from the fact that if your patient isn't going to do what you say do because they don't understand what you're saying, then that should be something that inherently you want to fix. But the thing is, like, I come from a background where this was a problem. I will use my mom again. She would not take her medication because she did not know what they were for. And so I would come home from medical school, write down all of her medications and write down what they're for. And then all of a sudden she just became more compliant. Like, I kid you not, her medical record just said non-compliant, but nobody asked her why. So I think it's one of those things where it has to be more of a curiosity. It can't really be you have to, this needs to take center stage. It's more of a curiosity. My patients don't do this. Why? And kind of be slow to hit that non-compliant, the word I want to use is not excuse, explanation as to why they're not doing it.
All right. Any other questions?
I don't have a question, but I do have a comment. I think you've inspired me to figure out how we in the state of New Mexico could do some sort of required rotation or learning experience for residents in this area specifically. I know we're starting to do it a lot more in the residency with Dr. Norris and Dr. Rachelson. And I think there's more in experience, but I think the residents, one or two residents do rotations here and there that focus on that. But many don't. And we don't have that. We're doctors, for God's sakes. And it's funny because we talk about health literacy. Well, we're illiterate when it comes to nutrition, right? We're illiterate when it comes to exercise. The new term that they're talking about is non-exercise activity thermogenesis, and it's just about moving the body, right? And So yeah, how do I build that literacy in the physicians in New Mexico? I think would be a good place to start. So thanks for inspiring me, because now I want to do something. I want to do something about that. So
So, Dr. Palin, I have a question, and it's just concerning, the holidays are coming up, and then that's when we tend to see a lot of the sweets, a lot of, the cultural holiday food. How do you approach that in terms of, behavior modification and getting people to either stay on track or, just indulge a little bit, but, kind of keep to it?
Yeah, absolutely. That's usually that's when the fear creeps in around October. And people are like Thanksgiving is coming, Christmas is coming, New Year's is coming, all this kind of stuff. So usually what I say do is I was like, I'm not gonna tell you not to celebrate. There it's gonna happen, right? You're gonna go over to whomever's house and you're going to eat and you're gonna have fun. My thing is go ahead, eat, have fun. The word is not denial, it's moderation. So if you eat and have fun on Christmas Day, great, wonderful. Maybe not carry it over from Christmas Day all the way to the day after New Year's, right? So also I have people plan ahead. So let's say, that you're going to eat a whole lot come Thanksgiving Day, right? Which is a Thursday. So maybe you eat a little bit lighter Sunday, Monday, Tuesday, Wednesday. And then when Thursday comes around, have at it. Maybe have a little bit leftovers on Friday, but then Saturday, the next weekend comes around, you're back on it, right? It's okay to have, days of celebration. What you don't want to do is fall off the wagon entirely. Also portion control, right? This is what I do for myself. My family likes to get those huge dinner plates that are like, they might as well be serving plates at this point. I just get a smaller plate. There's something about the eye that, like, if the plate is full of food, it doesn't matter what size the plate is, your brain for some odd reason says this is a whole lot of food, even though if you were to put the same little plate of food on a big plate, your brain thinks, oh, this is not a lot of food, right? So you're doing things that kind of tricks the mind and saying that, oh, that was a whole lot of food, I really enjoyed myself, that type of thing.
Excellent. Thank you.
Mm-hmm.
All right. Well, if we have no other questions, we'll go ahead and close out the session. Dr. Palin, thank you very much for joining us today.
Thank you for inviting me.